topic?
Yes, sir. Yes, sir. Next, the topic will be anesthesia information management systems. Dr. Sanjita will present, sir.
Okay. Sanjita, are you ready?
Yes, I'm ready, sir.
Go ahead, ma.
Good evening, sir. Today my topic is anesthesia and information management system. Anesthesia information management system allows automatic and reliable collection, storage, and presentation of patient data during the perioperative period. They are specialized forms of electronic health record system that, in addition to providing basic record keeping function, typically provide the end users with ready access to summary data that can be used to facilitate quality assurance and research function. The core functionality of an AIM center on the automatic and reliable capture of intraoperative patient data. Most AIMs today also include modules for storing pre- and post-operative patient information. The functionality of AIMS, first is the pre-operative modules contained in AIMS may simply be a place to input patient demographics like name, age, gender, ASA and physical status, and insert a free text note. Pre-operative modules that store patient data as structured data elements may provide patient risk stratification information. One major advantage of pre-operative modules is that they reduce the redundant data entry by carrying information such as patient's age and allergy across into the intraoperative chart. Prior to AIM selection, one should decide which components are important for the needs of the department as well as how the system will impact the existing work. For example, in order to obtain the maximum benefit of a pre-operative module, it may be necessary to install the AIM system in the pre-operative anesthesia clinic or induction rooms itself. Now, intraoperative charting has been the basis and continues to serve as the core function of any AIMS installation. The functionality encompasses two primary activities: the manual entry of case events, example case times, drug administration, and airway management events, and the automatic transcription of data from the patient monitors, example the vital signs and the ventilator data, into the accumulating electronic record. Finally, in order to be effective, the intraoperative interface should organize and highlight the critical pieces of the data as they become available in order to facilitate the situational awareness. This allows the end users to quickly identify the key pieces of the information, often by displaying a data element in a different color or larger font. For example, many AIMS will display an on-screen notification when an antibiotic is due to be re-administered. Next, what about the ergonomics? AIMS ergonomics. Most AIMS vendors recommend the mounting of touch screens either on the anesthesia machine or nearby. An adjustable arm mounted on the side of the anesthesia machine can typically accommodate both the touchscreen display and a full keyboard for any data entry. All the end users, be it the clinical or non-clinical person, will need to be trained on the system to maximize the benefits of an AIMS installation. Documentation and data definition. Clear and consistent definition of specific data elements and events will facilitate the uniform documentation. For example, there are many different definitions of the induction of anesthesia. Example, administration of a hypnotic, provision of anxiolytic, or start of pre-oxygenation. Data uniformity is important because it facilitates the billing, reporting, and increasingly clinical decision support functions. Finally, the availability of timely information is a means through which many AIMS can provide real-time decision support. What are the key areas impacted by anesthesia information management system? I'll divide it into three. Impact on patients. There is provision of real-time intraoperative decision support. It allows the anesthesia care team to focus on the patient rather than recording the vital signs only. There is better legibility and availability of the historical records. There is more precise recording of intraoperative data and the patient response to anesthesia. What about next is impact on the departmental management. The supply cost analysis by provider or type of surgery or patient. There is improved billing accuracy and timelines. It fulfills the Joint Commission requirements because it provides a legible and comprehensive patient records. It also facilitates the verification of Accreditation Council for graduate medical education case requirements for trainees. It simplifies the compliance with concurrency and other regulatory issues. What about the impact on the practice of anesthesia? It provides precise, high-resolution records which can be used for further educational purposes. It facilitates individual provider performance tasking. It enables the researchers to rapidly find rare events or specific occurrences across a large number of cases. It allows better quality assurance functionality through the creation of more complete and precise records. Provision of additional legal protection via the availability of unbiased and precise information. Next is what are the commercially available? Some of the AIMS vendor include the Drager, Accutech, then DocuSys. These are some of the commercially available AIMS system. What are the features, advantages and limitations of AIMS? Advantages include it facilitates a real-time clinical decision support. Accurate and automated intraoperative data collection can enhance the anesthesia record quality. It increases time providers can provide direct patient care, improve quality and accessibility of data for research, allows automated process monitoring and control, enhances the efforts to improve the patient safety and quality. It may increase the revenue capture. What are the limitations? No standard across AIMS vendors and limited system interoperability. Mobility and accessibility somewhat is limited because they usually run on desktop computers. Then limited vertical integration. The data does not easily transfer from one phase of care to the next. And the data collection may be prone to gaps. If there is any in between, if there is any system failure, there might be gaps in between. So that will not be recognizable and data will be lost. Requires significant effort and time for initial implementation, and installation costs and initial expenses may not be recovered in small practices. Limited compatibility and interoperability with other electronic systems. Potential introduction of recording or monitoring artifacts into a permanent electronic record.
Okay, good. So this is another very dull and grey topic, which very difficult to understand from the student point of view. Here again, I feel if I start telling you a story like thing as how I entered anesthesia and what was the method of keeping what happened during the administration of anesthesia. 1975, I entered anesthesia as an MBBS graduate without any qualification or without knowing ABCD of anesthesia, except reading about thiopentone and dexamethasone in my third year pharmacology class. I never knew what drugs are administered, how anesthesia is given. I had no clue. And at the time when I joined that, we were trained by one of the qualified anesthesiologists to start an IV line, inject thiopentone, give dexamethasone, hold the mask and then ventilate. No pre-oxygenation concept was not there at the time. And you have to keep the mask on the patient's face, activate the oxygen flush and then ventilate the patient for a minute or two, and then take off the mask and shut the oxygen flush and try to intubate with the laryngoscope, put in a red rubber tube and connect it, and then connect the patient to the McGill circuit and leave him for, once the Saksa effect wears off, patient will start breathing. Even for major abdominal surgeries, they were all done under spontaneous ventilation with nitrous oxide, oxygen and ether going on, because diathermy use was not there at the time. So all the bleeders were tied with either silk or catgut. So there is no risk of any explosion or fire accidents in the OT. So that was the technique that we were taught. And as I told you, there were no monitors except the hand on the pulse or the intermittent checking of blood pressure with a sphygmomanometer cuff. And no data recorded during the procedure. And at the end of the surgery, we used to cut off the ether, cut off the nitrous oxide, give 100% oxygen. And because the patient has been without muscle relaxants, they used to get back their cough reflex, gag reflex, everything, apply suction, extubate the patient and send them to the ward once the BP and pulse are adequate and patient opens his eyes to a command. We used to ship them to the even the concept of having a post-operative ward or post-anesthesia care unit was not there. So patient was sent back to the same general ward from where he came. So this was the situation. Later on, when I joined my diploma in Stanley, 2 years later, our chief insisted that we should maintain the anesthesia record intraoperatively. That was the first thing I was seeing. An anesthesia record was available. A yellow thick cardboard chart was there, and that was called by a name Noseworthy chart, where there will be a lot of there is a graphical thing you can do. You can put the systolic blood pressure to be marked by a downward arrow, diastolic with an upward arrow, pulse by a dot. So there will be it's a graph paper where you can put the timing, and then there are columns to write induction, intubation, maintenance, start of incision, end of incision, reversal. At the time only we started doing controlled ventilation also. I learned only after I came for my post graduation. So reversal given, all the drugs were, there was a column to write all the drugs. So this has to be very meticulously maintained by ourselves physically in the chart till the end of that, and go and keep it in a big ledger where we have to enter all the cases done on the day and keep these charts there. And our chief used to go through them the next day and ask us, why you gave so much of relaxant, why did you give so much of morphine? And morphine and pethidine were the only analgesics that were available. So he used to come and question if there is any complication. But if the cases went on well, no questions asked, so no audit or anything. So that is the way we were trained. Now, after the era of this manual dotting or noting the patient's condition, now we have come to an era where a lot of litigations are going on, because if something goes wrong to the patient, we have to go and explain to the consumer court or in the court of law what exactly went wrong, how we have managed and all that. So the courts now believe only a proper documentation will help to save the anesthetist from any litigation. So in order to do that, we have to be more careful. So nowadays, with the availability of computers, they have made this arduous task of manually recording all the vital parameters of the patient, which can be automatically drawn from the monitors, because nowadays we have all the multi-parameter monitors are available coming with the workstation itself. So the computer can draw all the data and the patient's condition, what was the initial BP before induction, what was the BP at the time of induction. Depending upon the time interval, we set all the pulse rate, BP, the saturation, all these, if you are using a muscle relaxant, the train of 4, everything can be documented, and that information can be stored and utilized. One, to analyze how the anesthesia intraoperative course went on. Second, later on, if any complication occurred, at what level we went wrong or what mistake was done. Or you store all this data, and then if you want to produce a research paper, you can pick out the similar cases, patients with hypertension coming for Whipples. What is their behavior? How the drugs altered? So if you want that, you can, by a click of the button, you can get all the number of cases that have been done. You can analyze them, you can produce a paper. Okay, so from research point of view, from the management point of view, and from any legal problem later on coming, supposing some calamity has happened and the patient's relatives go to the court, you can produce this record to say that everything was done in the correct way, and some mistake in the patient's system, his own response, something went wrong, and that is how the calamity has happened. So it can protect you from any legal problem also. So all these things are now termed as anesthesia information management system. That is what is called AIMS. So the management part of it is about the preoperative condition. As she started saying that preoperative module, at that stage itself, we can store all the data, analyze them, and give the ASA classification to the patient. And based on that, ASA classification, what is the purpose of ASA classification, Sanjita?
Sir, risk
Risk involved.
risk
The-
involvement.
For the morbidity and mortality. So as the ASA grade increases, the chances of morbidity and mortality are high. Okay. So by getting all the data in the preoperative phase itself, we can assess the chances of morbidity and mortality by giving the patient the correct ASA score. And second thing is, we can optimize and put those data also in the computer, and that also can be stored. That will be useful to manage future cases when you get a similar case like that. So this is the first management and information that you utilize in the preoperative phase. Second, coming to the intraoperative phase, the same computer is going to grab all the data from the monitor and store it much more efficiently than you physically writing or jotting down in your anesthesia record every 5 minutes or 10 minutes. And you have to spend time to make sure that you are writing it correctly, because if you make any corrections or overwriting, that is also considered as cooking up the results or the values. That will be not accepted in the court of law. Whereas if it is being taken by the computer from the monitor, it becomes more authentic and more correct method, and relieves you of the burden of monitoring or looking at the monitor every few minutes and then jotting down it on the piece of paper with a pen all the time. So this is the intraoperative adjustment. Then nowadays it has been expanded to the postoperative phase also, where depending upon the intraoperative behavior of the patient or the need for a planned elective ventilation or a inotropic support or a fluid management, all these things can be extrapolated and taken to the postoperative phase also, where all these things can be monitored, and ultimate aim is to get the patient in a very, very smooth way out of the hospital without any mortality or morbidity. Okay, so this is what the AIMS, anesthesia information management system, helps to maintain a successful outcome of the patient. So that is the basic concept that you have to understand, and in that way you have to classify and then write this information, how it is helpful. And as he said, it is going to be the future. Now we are all retired people, I don't know, I will not be seeing all these things, but in future it is going to be the thing in the day-to-day management. So you need not have to write the chart that you are now practicing in some hospitals. Everything will be automated and everything will be there, and you can get the information by clicking the patient name, ID number. Then you get all the intraoperative behavior, post-op behavior, pre-op status. Everything can be given, received from that computer in which it is stored. And these records are stored well in the computer for any number of years, unlike your manual recording where the papers can become old and brittle and even tear off. These things cannot be spoiled, or it can be stored for many number of years, and you can utilize it from all these angles. So with this explanation on this topic, I just share you the PPT.